I would like to introduce our moderator, Danielle Chammas. Danny?
Hi, all. My apologies for being late. It's ambitious to put things in the evening when you have three kids, but here I am. And I wanted to thank you all for getting started and just introducing yourselves. I did want to say I put a link into the chat if participants, not the panelists, but if participants could take just a minute to do a quick pre-survey, it really helps us understand your needs and your questions and make sure that the program is serving you all. I'll give you just the briefest background about our program before jumping into some extra questions for our panelists. So, essentially, over a decade ago, when I went from psychiatry to palliative medicine fellowship, I adore my career, and it was quite the journey trying to figure out the path and find mentorship and integrate the skills and think through career. And now that there are just a number of us psychiatrists who are working at the interface of palliative medicine, we all sort of collectively wanted to make sure that we can be a resource to people earlier in their journeys, because we know that this type of mentorship might not be available at all of your institutions. So the PalliPsych mentorship program, we have quarterly events. Three of those are sort of open office hours, group mentorship sessions. Show up, ask your questions. We purposely don't record those for confidentiality. And then once a year, we do something like tonight, which is more of a career panel with a number of panelists who can share their stories, and you can get to know them a little bit better. We have one from 2023 with 4 psychiatrists who did HPM fellowships, one from 2024 with 4 people who were sort of within 1 or 2 years of their fellowships, so really fresh insights and outlook. And one thing we always get asked every time without fail is around discerning between Consult-Liaison and a palliative care fellowship, and trying to figure out what the difference in experience would be, what the difference in jobs would be, things along those lines. So I'm very excited for tonight because, as you all heard, we have 2 panelists who were CL trained, 2 who were palliative medicine trained, all of them psychiatrists working at the interface. So really excited to have their perspectives as you all discern what paths might best align with your personal goals, because there is no one right path. So thank you, panelists, for being with us tonight. Thank you for sort of introducing yourselves and your path and what your career looks like. And I'll ask a couple of questions, and audience or participants, throw your questions in the chat because we'll leave some space for Q&A. So I'll ask a couple of questions and then I'll try to summarize your questions and get them all back to the panelists. But it sounds like you talked a bit about your path. So maybe I'll jump to the question. Could you all share a little bit about sort of the biggest challenge you encountered or are encountering, and the biggest unexpected gift or joy that you found because of the path that you took? They're all psychiatrists, so they can all sit with silence really well.
I can take a first stab at the answer if you want.
Yeah.
Frankly, one challenge for me, I so much like all the different domains where a psychiatrist can work and where a hospice and palliative doc can work, that I found it hard in my 5 years since fellowship to want to be in only one of them. And so sort of a positive spin on a challenge, which is simply that I enjoy all the various settings of it for a variety of reasons, and find sometimes one setting complements another setting, and the experiences in one venue, not only within one specialty but across the 2 specialties, can inform my approach in another. And then an unexpected joy, I don't know, to me, I mean, hospice and palliative care, end of life care, was really my calling in life, and the richness of it, the unexpected moments, just existential moments, and appreciative moments from patients and from families, and the little twists and turns that one simply can't anticipate are the unexpected joys of it for me.
Yeah.
I can piggyback off of Shapir in that I share a similar experience in the challenge being like the doors that closed based on my choice, which is kind of like a firm way of putting it, but I'll elaborate, which is that the doors that opened by choosing to pursue the route of psychiatry, which became a no-brainer for me once I discovered my love for it, was to become a psychotherapist. I didn't realize that I wanted to like do psychodynamic psychotherapy and pursue that route. I went into psychiatry residency wanting to do psycho-oncology and palliative care. That was always my thing. But that discovery of the love of being a therapist was what helped me make the decision to pursue CL, because I knew that then I could, go on to practice as a psychiatrist. And what I didn't expect was how those skills were going to become so valuable and useful to me in working at the interface. But the door that closed that I didn't really realize how much I would miss out on was the discovery of what it was like to work in hospice, which is only something that I got to do as a result of our psilocybin-assisted therapy research. The first study we did was working with a hospice population and going and doing home visits and like really being at the bedside, like in the moments of, I think, what can only really be encountered there. And I totally fell in love with that and have ever since kind of lamented that that's not a door that's readily open to me as a psychiatrist without extra palliative care training. And you can approximate some of that, in moments in clinic and in the inpatient palliative care unit. But again, I think it's a choice that I made. And I think that there's magical things to be found at either end of the spectrum. It's just definitely like hearing Shapir's reflection made me think of that as being like a challenge and also a joy.
I think I'll go a different way on the answer for this. I think for me, so in my path, I'll just share. I am in my third job since training. I stayed at 2 places for 3 years and have been in my current job for 4. And what I have actually found most difficult was that I think in our training, I was pretty unprepared in terms of my understanding of the business of medicine and the sort of administrative stuff that people think they're protecting you from in training sometimes. And then you come out and you're just expected to sort of understand it. And it's particularly important when you pick a job where you're really sort of straddling 2 worlds or have maybe multiple bosses or your funding comes from multiple sources. And that often happens in this area. And so I wish I had asked for more training in that. I wish I had asked more questions of my attendings about why things were the way they were and who paid for the services we were offering. And so I think that also goes with a little bit of some advice, right? And that's something that you may have to seek out intentionally, but people are willing to talk about it if you ask. And I think that's been the biggest hurdle for me personally, because I was capable of seeing patients and doing my job. It was the other stuff that you sort of have to learn on the go that became more challenging. I think the greatest joy for me is not really a surprise, but I love collaborative care. And in this role, there's like an endless number of people to collaborate with. On every patient, I may be talking to 6 or 7 other providers after a visit about what happened and what we're going to do. And I just love that aspect of the job. It's not something I would ever give up.
I was gonna offer that some of the challenges I've encountered kind of in these first couple of years, for me, I think really takes me back to sort of like the job creation decision and space. And my decision to pursue palliative care fellowship was not like contingent on becoming explicitly a palliative care physician. In fact, I was actually wondering if I would end up practicing full-time psychiatry afterwards. And so it wasn't kind of seeking a particular like destination job. But for a couple of reasons, both professional and personal, wanted to try and stay in Los Angeles and maybe even try and stay at UCLA where I was completing my training. And there's just a lot of uncertainty when there aren't templates or a lot of people who have sort of practiced in similar split ways before. And so there was a lot of distress tolerance practice and opportunities for things to get delayed and a lot of uncertainty, like I said before, about if I was going to be able to sort of build a job in a way that was going to be able to split two different departments and borrow time here and there. And all of that gets in the weeds really quickly. And I want to kind of pull out from that and just recognize that I was really excited about the chance to even get to do a little bit of something like that. And, but want to recognize that there can be a little bit of additional like heavy lifting to try and get something started in a lot of different ways. And that isn't just exclusive to psychiatry to palliative care. I think one of the things I really love about my job is that I get multiple kind of clinical homes and academic homes and communities at work. And I think for me, having social connection is like a really big, and fulfillment is a big part of my professional life and hopes. And I love that I get to be in our Psycho-Oncology clinic and the infrastructure here, and get to be in our general outpatient psychiatry clinic with residents and re-engage with faculty there, and then also with palliative care faculty in the hospital. But I will also say that there is an edge to that where even though my roots may not be like that deep, maybe it's a time thing or whatever, but there are moments where I feel a little bit unrooted and feel a little bit listless between my communities, or that there can be a degree of loneliness or isolation if you're not kind of thoughtful or investing in some of those relationships. So it certainly bends both ways, but wanted to recognize that. And then similarly, like defining growth for myself. And I don't mean that in like a superficial trying to get promoted way, but I mean more just like how you want to grow as a person and as a professional when you're holding a couple of different spaces. And I disproportionately do more outpatient psychiatry and less inpatient palliative care. And so the rate of like growth and change, I feel like, is slower for palliative care. And that's something that I spend some time reflecting on. Or is it nice to be able to sort of like pivot and switch spaces more frequently? So I'll stop blabbering. But I was just going to offer, and perhaps not unexpected, but like the heart like wrenching and opening joy and gratitude. Really, it's gratitude that I wanted to come back to from getting to do this work that's oftentimes like steeped in so much sadness and tragedy is just an incredible gift, and is such a life force for sustaining work, and really excited to share it with you guys tonight.
Awesome. Thank you all. There are pieces of each of those stories that I resonate with. The next question I was going to ask is if you had one concrete piece of advice that you could give to trainees who are considering, do I want to do a CL fellowship? Do I want to do a palliative medicine fellowship? Or to the educators that are supporting them, what would that advice be as they discern this really important decision?
I guess I can go again since I was just so wound up. My first advice would be do the fellowship. And either one's gonna be awesome. Like I think if you're at all interested in this like general scope of work, welcome. I'm so glad you're here. Like this is just really awesome and fun and rad work to get to do with great other people. So do it. But my more salient advice is to try and connect with mentors on both sides. And recognize, as it took me a while to really come to, that institutional variation and how CL may look, or how palliative care may look, or the relative progressiveness of an institution and how they've integrated psychiatry into serious illness spaces. Like, I think trying to get mentorship and just touches on both sides at different places. I wish I could give that advice to myself kind of from before. And then just, I guess, related to that is for educators to support building relationships between maybe psychiatry training spaces and palliative care groups, mixers, lunch talks, defining jobs, blah, blah, blah. So, all right.
I can go next, because I was thinking about the answer to that question when you sent out the, potential prompts for our discussion tonight, Danielle. And I see it. I see that these two training paths and fellowships are fundamentally different. Yes, some similar patient populations, but really fundamentally different in important ways, as I see it. I think that someone who wants to go into hospice and palliative care is someone who really wants to work with the dying, to work with the terminally ill, to work, of course, more upstream from that, and to help the dying, and to die as comfortably as possible, psychologically, existentially, medically, etc. To help the families through that process, but with in an all-encompassing sense of working with the very ill and the dying. The way I see Consult-Liaison work is yes, some of the patients, but certainly not all, might be quite sick, might be dying, but it's, in my view at least, more of psychiatric assistance to those, medically ill folks. And it's not per se being the person to help really manage end-of-life symptoms and vent withdrawals and the like. And so I think that a trainee ought to think about, what really is it that that summons me, that compels me, in a concrete sense. Does someone like being pure consultant in the way that the CL perhaps is more limited to, or certainly in hospice and primary, not only can one be consultant, but one can also come to be a primary, attending for patient. And so I think they're very different. I could draw similarities too, but that's some of what comes to mind.
Great. Kaleena or Roxanne?
Oh, no. What I think all comes to mind for me is the idea of also just being flexible, right? Like, I think, Rox, we talked about some of the challenges of sort of once you pick a path, there may be some kind of boundary sort of built in around what you can do. But I also think there's a lot more flexibility than we often realize. And it depends what location you pick, what kind of setting, what your report structure is. Right now, I work within a department of palliative medicine, and I probably share 60% of my patients with PalMed docs. I manage a lot of physical symptoms as their psychiatrist, right? Because I have this team that sort of backs me up that I can ask questions of, or I can say, hey, they're saying their neuropathic pain's pretty bad today. I'm thinking about bumping up their venlafaxine. What are your thoughts, right? So I can end up managing a ton of physical symptoms, and not always just with psychotropics, because that's the structure of our system and the way it was built. And that may not be the case in another setting, right? And so there is some flexibility in how you might navigate a job. If you find yourself in one position where it doesn't feel like it's the right fit, that doesn't mean you picked the wrong path. It may be that's just not the right job, and we need to make some changes, or maybe even switch, or navigate. But there is a fair amount of flexibility, if you're willing to sort of roll with it when things come about. And I say that as someone who didn't even think psychiatry was going to be my path, right? I was president of the emergency medicine interest group at school. So, sometimes you got to roll with it and find the right matches once you've made a commitment, because they're out there, right?
Yeah.
The other thing, more practical stuff I would add, like, sign up for electives early, right? Do PalMed rotations, do psychiatry rotations, really, really feel it out. Tell the attendings you're thinking about these choices. Be open about it, because they'll help you make choices, and they'll be open about their paths too if you're a trainee. And then I would say join national organizations, especially as a trainee when the costs are cheap. up when you get out, right? So sign up, join AHPM, but also maybe pick like a CLP and join them both and see what people are really doing and how they talk about their jobs and what they like. And if you pick like one or two special interest groups, you get these very small groups where it's easy to reach out to individual people and say, hey, can I pick your brain about this? I want to, join someone. I probably once a month talk to a trainee I don't know who's just reached out because they want to feel something out or ask a question, or they're trying to build a program somewhere and want some advice. So that's really, really common, and you shouldn't be afraid to do that. So just start putting your foot in the door, and you'll find lots of people willing to help you make decisions.
I don't know that I have too much more to add to what the other panelists said. I think that one thing that it's something I didn't know, and I happened to land now in a position where I realize how important this is that it's something that's already been said, like where you work and how things are structured are so important. And I happen to work at Dana-Farber. It's a huge cancer institute. The divisions of palliative care and psychosocial oncology are housed under the same department, and we have the same leadership, and we work so closely together so that the distinction in some ways, kind of like to Kaleena's point, I share so many patients with palliative care that there are times where I feel that the scope of my practice starts to encroach into more of what would be considered a typical palliative care, even though I am a CL trained person. But I guess I go back to, for me, I knew I had a parallel but distinct interest burgeoning, which was that of psychodynamic psychotherapy and psychodynamic thinking. And I was already excited about how I could apply those types of principles to practicing in the psychosocial oncology and palliative care space. And I thought that doing a CL fellowship was the best way for me to position myself to develop those skills further. So I think if you know, like, for example, if I had known that I had this real interest in like very, very close attention towards the very, very end of life, that might have influenced me maybe to go, and I'm sure there are ways to do that, like as a CL trained person, but that might have swayed me to head more in the hospice palliative medicine fellowship direction. So I guess the concrete advice is, if you know you have a special lens or way in which you want to approach the work, if you happen to know that already, try to feel it out and let that influence your choice, because it does. I practice very closely with a good friend and colleague who is a psychiatrist residency, hospice and palliative medicine fellowship trained person. And we talk all the time about how, like, even though we have the same training, like, we diverged, and there are big differences that have kind of come along, and we work so well together. But it does make some difference, I think.
Absolutely. I'm also seeing Jordan Stone. I don't know if I can turn a participant into a panelist, but Jordan, I'm seeing, answered the question in the chat. Jordan said, I navigated the question of CL or palliative, and it became a very practical one. If I ever wanted to do palliative care, I would need fellowship training, but you don't necessarily have to have the CL fellowship training to do the CL work. So sort of a sense that maybe it opened more doors to go one route than the other.
I think that piece really resonates with some of where my head was at during the decision-making process around fellowships. And what was a helpful value to identify for me was an interest in spending more time around serious illness and considering if it would be useful to sort of be a little bit more upstream than like a psychiatric consultant in the hospital, for example, and to spend some time with like a lot of folks in medicine and to see what questions and issues they're wrestling with and how they're deciding to approach the convergence of psychiatric comorbidity or normative psychological processes. So I really thought of it as like a proximal and distal type of skill set. Like, one was honing and specializing the psychiatry skill set foundation that you build, and one was just this more like, I don't know, more distal leap, I guess, more experiential learning, more immersion, and that has complexities and pros and cons to it as well. But that was helpful for me to clarify as well, feeling like I was comfortable with and wanted maybe that more distal experience, and then could kind of fill in the gaps in between depending on where my interests started to, as that cookie crumbled, like where they went.
Absolutely. I would just add to the discussion, for me, and I realized this when I was on a palliative medicine fellowship, there just felt like there was a room for psychological support and the holding of that kind of space and existential exploration for everybody. And where I trained, only a fraction of those people made it to Psycho-Onc or got to see a psychiatrist. And so I had just a personal calling of like, gosh, I want to take the really rich skill set from our field and offer it to the entirety of this other field rather than just a subset. But I am equally grateful for my colleagues who are like leaning into, really figuring out how we manage depression in this space and things like that. So again, there's not one right path. It's just the path that you think calls to you most, and together we make it a lot better as a cumulative effort. So
Andy, before you move on, I just want to advise a little caution about the comment that was made, because there are lots of psychiatry CL jobs that do require CL fellowship out there. So like every job I've had has had a requirement of having done a fellowship, right? So if you want to go into big academia, for example, or perhaps want a really high administrative job, you want to run a department or be involved in administration or education, perhaps on a higher level, fellowships are still a requirement for a lot of those positions. So I just want to hedge that a little bit, that it does depend on what your goals in your career might be, whether or not a CL fellowship would be required for a CL job.
yeah, absolutely. Please, I encourage you all to put questions into the chat. Okay, here's one. How do psych palliative trained physicians position themselves well when looking for palliative jobs in a pool of family medicine IM trained palliative physicians?
I don't know. I can take a stab at that, though I don't have a lot of experience. I can say, first of all, I don't even know that there's a need to position oneself well. Some places are inviting and welcoming of the diversity of experience that a psychiatrist has, as opposed to an fMRIM doc. So it's not necessarily a level playing field because we come from very different residency backgrounds, which is actually a feature. It's a perk in the eyes of some. In those for whom it's not. I don't know that any amount of positioning would overcome whatever the preconceived prejudice might be. And to this day, it's become more rare. But I remember some years back seeing palliative help wanted ads that are that specify FM or IM only. And always sort of wondering, is that even allowed these days? But clearly, whoever was doing the hiring there had their preferences, and so, probably, anyway.
John, any other thoughts?
No, my instinct was to position yourself as a good candidate, and to make the most of your fellowship. And I agree. I think trying to be a good job candidate will speak for itself.
Yeah.
And the diversity of the background, regardless of if it's psychiatry or another, I would say, non-traditional or less typical, my hope is that would be met with equal support, which is, I think, a really nice core value of interdisciplinary and interprofessional support in palliative care and other spaces.
Absolutely. And I would say that it's an evolving landscape. Like when I was first applying for a fellowship, half the fellowships wouldn't even take a psychiatrist. There was a lot of questioning, and I think the field of palliative care, it has a lot of movement right now around the role of psychiatry and the wisdom that can come from psychiatry, to the point that I think there are some institutions who still might be hesitant, and there are others like our own. My chief was like, man, we want to get another psychiatrist, like help us recruit this person. And so there are some places where I almost feel like it's positioning you really well to have this training, because people are increasingly seeing the need. And then Gail, maybe we can make Jordan a panelist, because Jordan, it seems like you've been through some of this, but I see Jordan in the chat saying that Jordan experienced some some skepticism about being able to keep up, but it was more of an anti-psych bias more than anything. Yeah. Oh, there's Jordan. Hi, Jordan. Welcome to the crew.
Hello. Thanks for letting me in.
Of course. Why don't we take a moment while people are still putting in their questions? Maybe you can give us some thoughts. And then I also see another question that people can percolate on as Jordan is speaking. But the question is, are there any palliative care fellowships available for professionals that are academic or programmatic staff, say with an MS versus a clinician with an MD, PhD? Let me think on that one. Jordan, why don't you tell us a little bit just about your experience in general and if it resonated with what the panel's been saying tonight?
Yeah, I mean, largely a lot of the same kind of questions leading to fellowship training, some of the same challenges navigating, deciding what path to go down. To kind of answer the question about positioning yourself as a candidate, I mean, I was met mostly with like enthusiasm, like, oh, this is so great that you're interested in this field. And since being an attending, it's been nothing but positive regard. Like I mentioned in the comment, I did encounter some like skepticism from people, but I think those were mostly like folks that just, practicing from a different environment in the past, kind of, and probably fueled by like just kind of general, psychiatrists can't keep up with the medicine kind of thing. And I just was like, I guess you'll just have to see that I'm also a doctor, so I can do doctor things too, and talk about and think about feelings. So it didn't end up really being an issue.
Awesome. I don't know the answer to this question in the chat. I think that there are some like masters in palliative care programs, but I don't know.
I don't think I'm not aware of anything for clinical. I mean, there is the PhD, and I think they have a master's program at the University of Maryland in palliative care, but that doesn't usually lead to like a clinical position. I think that's more for folks that are research oriented.
Yeah. Well, panel, I'll throw another one at you guys. Can you tell me a little bit? This is such an evolving landscape. Even, in CL, I think what used to be very siloed is becoming less and less siloed as psychiatry and palliative intersperse themselves. How much were you able to create the role that you wanted versus how much did it just exist? And how did you get mentorship there and learn the ropes there?
I can go first on that one. I completely created this job. The Cleveland Clinic had been looking for a psycho-oncologist, had a psycho-onc position listed for years, actually, and had a hard time filling it. And I'm a Midwesterner and wanted to get back to the Midwest, so it was very appealing to me to be able to get closer to my family. And they essentially said, like, what do you want the job to look like, and how should we structure it, and who do you want to hire? And so I had, a really lovely position of being able to do that. And I'm a little further out of training than some of our other panelists. So I had some experiences running other programs and had gained some wisdom about what was important and what I did want to sort of put emphasis on. So, I didn't really negotiate my own salary, for example. I negotiated people. Right? I said, like, here's who I want to hire, like, now, and here's who I want to hire in a year. And that, got to sort of set some parameters from the get-go, which is a lovely position to be in. And I recognize not always the ones we walk into, but something you can find and can do in these fields where you're highly specialized, and there aren't a lot of people who want to do the work. So it is a blessing that also comes with this.
Kaleena, I'm going to call you the next time I negotiate anything.
Go for it.
I will add a quick answer here because my experience in residency, when I was feeling so driven to get involved with psycho-oncology and palliative care and was training at a place that didn't have any infrastructure for that, was that I practiced getting that set up and happened to have a mentor within CL who was really supportive of that. And so that kind of primed me to think that that was what I was going to need to do once I left. And then what ended up happening is I went and did my training at a place that had like a big, robust infrastructure already set up, which meant that I didn't have to hustle and figure out, like where the money's going to come from and how I'm going to get funded and what can I have and what can I do. Rather, it allowed me to kind of create my own niche within the field, which has been really great. For example, I created the position of the psychiatric liaison to the inpatient palliative care unit, which was something that the program and the division was really supportive of based on my experience doing an embedded liaisonship during fellowship, building relationships with the IPQ team and, them becoming interested in having more frequent presence and then having official supervision for the fellows and trying to build up the program. So I guess the short answer is I think it depends a lot on where you are. Where I was doing my training, there weren't programs and people and things set up, but with enough enthusiasm and excitement and figuring out how to do stuff, everybody was excited and wanted to have the service. And then if you go and work at a big academic place such as Dana-Farber or some others, it's easier in some ways, but more difficult in other ways, I think, to really write your own ticket. But I think that's the beautiful thing about this space is that people are, I feel like by nature, just really collaborative and creative and wanting to find ways to work together and create new positions. So I think that that's going to be something that will be exciting wherever you end up going.
I was going to offer that in some ways, I was able to lean on relationships that were slightly pre-existing to the actual explicit time when I was trying to build a job, and had the benefit of rotating through the clinic that I work in now as a trainee and building relationships in that space and being in touch with them as the oncology enterprise at UCLA is growing quite a bit, and checking in with them about future need and things like that. And then staying here, the benefit of staying at the same institution is I was able to maintain relationships in psychiatry while I was moving through fellowship and meeting all these folks who are mostly Department of Medicine based and in very different spaces, and also recognizing that they are also really hungry and hoping to build more kind of mental health support services for their patients that may not be captured in the oncology ecosystem. And so there's just so much interest and need. I mean, I think at the center of all of this is the really demonstrated clinical need that we all appreciate, but maybe others are catching up to in a variety of ways, or investment is maybe catching up to. And so finishing fellowship and moving through fellowship and sort of putting those together, our UCLA was also hiring for palliative care jobs, and I was able to start a conversation that really was I would like to do a little bit of both. Is that possible? Which had a real twisting and winding road, including one of my main job champions leaving UCLA and navigating how to figure that out. But I would say there was no clear template and no sort of near-term role model, but there were folks that were supportive, and I think that is sort of the really important substrate for something kind of coming to be.
And those of you listening have us, but Shapir.
Yeah, my quick answer is that I don't know if intentionally or unintentionally that my years since fellowship, I think I've tried to simply sample the different work environments and job descriptions, and so as to see what I like, what I don't like, to perhaps better inform where I'd like to be. The initiative is sort of it's become self-defeating because I like all of it, but that I think was so there can be a thought to doing that as well. I mean, fellowship in theory gives a person time through different rotations, whether it's a CL fellowship or a palliative fellowship, to feel out the different work venues, inpatient, outpatient, home visits, and the like. or even away rotations at different institutions. And no reason one couldn't continue to do that for a time as an attending too, just to see the cultures of different institutions and what opportunities there might be elsewhere.
Yeah. It's a really nice point about cognitive flexibility. I almost took an opposite path. I dove straight into palliative, full on palliative, and was doing a lot of psychiatry in that because there's a lot of psychiatry in it. But then I started to realize which things I missed. And it's such an evolving field that I was like, okay, well, now I want to do a dignity therapy pilot in my palliative care clinic. And now I want to do a poetic medicine pilot in my palliative care clinic. And it's morphed over time, like pulling in these different threads of our training. Jordan, I saw you unmute for a moment, so feel free to chime in, of course.
Yeah, I was just going to echo. I kind of my experiences go closer to like what John was saying. I certainly had a lot of questions in my fellowship. They were like, "So, what are you going to do? Are you going to do psych? Are you going to do palliative care? Are you going to do something of both?" And I was like, "I don't know. What can I do?" And I had mentorship from both psychiatry and palliative care, but there was no one that came from my background, so nobody could really give me very, very practical guidance on like, yeah, here's what you can do with split time. So it was very hard for me to come up with that de novo because like I didn't know. And the practical realities of like your funding streams, the sustainability of the role that you create, like that's all really important stuff that you probably are not super prepared to comment on when you're a trainee or early in career. But it is stuff that will come up when you start to be like, yeah, I'll do both. And they're gonna present you with like, okay, so how are you gonna make this happen? And you're like, I don't know. I had a couple of experiences when I was looking at jobs where the location and the just general supportiveness definitely was a major factor in that. It's like I had one hospice job that I was looking at where they were actually going to offer me a split role, being a hospice medical director and serving as a psychiatric consultant for the hospice agency. So like they were just really willing to like take my background and like kind of create something totally new they'd never done before. And then I had plenty of other jobs where it was like, yeah, no, it's just one or the other, and like you got to pick what you want to do. So it's tough. I think if you want to try to do both, you have to just be prepared to really think hard about the practical aspects of how you're going to balance the role in two different fields with kind of different demands and needs.
Yeah. And hope that systemically things change to remove some of those deep silos. A question in the chat. A lot of research I've seen in psychedelic-assisted psychotherapy and end of life is being done by internists and psychologists. Do you have thoughts about how to get a foot in the door to this world, or what a CL or palliative trained psychiatrist role could be?
I'm guessing that one's for me.
We were all looking at you.
So this is a field of a lot of growth, and there are a lot of groups popping up across the country and internationally that are doing research on this. And our group at Dana-Farber, there's 3 of us. 2 are palliative care physicians. 1 is psychiatry trained with a palliative medicine fellowship, and the 3rd is me, psychiatrist with a CL trained fellowship. There's another group at Emory that I know is headed by a palliative care doc, along with spiritual care. I know there are a number of other programs cropping up that palliative care and CL psychiatry are actually a really strong presence as the principal and co-investigators. So I think that that's changing and evolving. As far as what the role of a CL trained psychiatrist versus a palliative care trained psychiatrist could be in those spaces, I think that that's like a longer question that I would be happy to talk with offline if someone has serious interest in that. But as far as getting a foot in the door, I think that what I always tell people is that having like a really solid basis and identity in who you are as a clinician is really important before getting involved in a space like that, where there's so much excitement, so much hype, so much unknown. That's kind of the way that I lead when there is so much interest, understandably, around something new and exciting. I think the important thing is if you are really interested, there are a number of training programs that can expose you to learn more about those treatment modalities and see if it's really something you want to get more involved with. And then I would say the next step would be to see if there's anybody at the institution you're training at that is doing that work, or even at conferences, people are going to be talking about and presenting work in that space. I know I'll be talking at ACLP this year, maybe also at APOS. And, I know that my colleagues are speaking at AHPM about it too. So I would say that there's definitely welcoming presence and space for HPM and CL psychiatry folks within that research space. But also, I would say it's like kind of a rapidly growing field that I think we need people that are really grounded and solid, like in their therapeutic orientations coming in and joining the show. So I would say like stick with, developing your professional identity, and it's not going anywhere.
Yeah. Awesome. Well, we are 1 minute away. First of all, thank you so much to our panelists for their generosity of time and spirit. All four of you, plus our bonus panelist, Jordan, thanks for joining us here. And then for those of you out there, none of us ended up in this space without having a calling to it. And there really is a true beauty to getting to work with people at this deeply impactful and meaningful part of their lives and being invited into their team and their journey. And so we're excited that some of you are called to do this work, and we also don't want you to feel some of this out at ship alone in a space that others haven't traversed, feeling that some of us felt when we were going through it. So know that we are here. We are a growing, very fun pool of people, and reach out to us. We'll have another mentorship session coming up later this year, and I see people are putting in their emails to the chat. You can also just email Gail, and she will help connect you with anybody that you want to connect with. And if we're not the ones, if you want to talk to a private practice psychiatrist who's doing only like existential therapy, whatever it is, we'll connect you to the people we know who are the ones who might be able to help you out. So with that, thank you all. Have a great night.